Yes, doctor.
Yes. Can, doctor.
Okay, just a moment. Share. Okay, Assalamualaikum and very good evening. Okay, so okay. Okay, so we're going to discuss maybe tonight the surgery or reproductive system. So we start with female first. I think we familiar with the female reproductive system surgery. Okay, so in DVM3 we learn about OHE. So at this VPK 3712 we're going to add a little bit more of the surgical procedures that we're going to encounter. Yeah. So for OHE or sterilization technique, in DVM3, we only learn about traditional midline, but in reality, you have basically 4 techniques that you can use to perform your OHE. One is traditional midline. The second is the laparoscopic. Third is the flank and also the ovarectomy. Okay, so ovarectomy can be performed with flank or laparoscopic or traditional because it's basically just remove the ovaries, okay, but you leave the uterus in the patient. Okay, so these procedures more popular in the Scandinavian country like Norway, Switzerland, something like that. Okay, so they have their judgment lah. But in here, I still prefer really encourage our practice to perform the traditional midline. I still prefer to remove the uterus, okay, because we know that uterus is can be a causative issues for our patient, especially nowadays. Our patient they live quite a long age, yeah. Okay, so okay, so this is probably you've seen this slide before, sorry. So ovarian hysterectomies, again, it consists of the ovaries, hysterectomy, which is the uterus, ectomy part. So basically it's removed, and it is actually the indication why we performing OHG is basically for elective sterilization, preventions of diseases such as mammary tumors, uterus and ovarian neoplasia. Also, this is a treatment of ovarian and uterine diseases like cyst, pyometra, torsion, prolapse, or cyst pyometra. Okay, so for surgery, it's very important for OHG, you know your skin incision location, the origin and location of the blood vessel that you're going to deal with. In OHG, very important to very clear the ovarian vessels and uterine vessels. Know where is the origin of your suspensory ligament and also the layout of proper round ligament, mesovarium and mesometrium. So if you're not familiar with this, please open up your anatomy books, okay? So this is from Slater. This is a diagram to show the conditions of the uterus suspended in a patient, okay, or in an animal. So you have your ovarian bursa. So basically, it's a fat that contain your ovaries inside. So when you do a drawing, if I ask you to draw, can you please draw and identify the anatomy? Sometimes I'm not sure whether I want to give marks or not because you just draw this huge giant circle and say that it's a ovary. It's basically not. You got to draw something like this. Since you are doing veterinary medicine, please be a detail. So this is your ovarian bursa. Inside your bursa, you have your ovary, okay? And then your proper ligament, a very important ligament in during the OHE. And then you have your suspended ligament and you have your ovarian vessel here. So what is very important here is, not sure whether you can see clearly or not, but take note that there are differences between the right ovarian vessel and left ovarian vessel. Okay, so what is the difference is your left ovarian vein is actually branched out from your renal artery, renal vein. Can you see here? So when I ask you to draw, this is very important. This is very important for you to take note. Here, it's branched out from your renal vein, okay? Compared to the right, it branched out from your abdominal artery and vein, okay? So, so please take note this, yeah? So looking at this diagram, you should now realize why drop pedicle is dangerous, because it is a direct branch of this main giant artery and vein. Okay, so that's why once you drop your table, you have to quickly identify. So basically what we can do is actually extend the incision quickly. That is why I always ask you to prep larger area. Even you already practice in future, prep a larger area in case in future you drop pedicle, you don't have to struggle to want to skin prep intra-op. Okay, you can just extend, and then the quickest way basically is to look for kidney, and basically the drop pedicle will be just underneath your kidney. Okay, so really you need to able to imagine when the blood is pooling, you need to able to imagine basically where is your the drop pedicle area. Okay, so please take note of the ovarian vessels. Not sure why this is branches from renal vein. So basically it's the creation is like this. Okay, so next, for for the skin incision, okay, for cat we usually would aim at number 2 region. For dog, it's number 1 region. Okay, so it is closely related to the locations of the uterus. If, for example, if for cat you make an incision at number 1 region, so this is the umbilicus, this is the pubis. So how I want to describe is from the distance between pubis to from the umbilicus to the pubis, you're going to divide it into a uh, um, three portions, three equal portion, and then for cat we do the incision at the second third. Okay, so in cat, if you do the incision at the first portion of first third of this distance, you what you're going to get is actually a lot of intestine gushing out. Okay, so we don't want that because it is interfering with your spay hook usage. Okay, so if you incise here, you probably we find your bladder, and it's make your fishing out or hooking out your uterine body or uterine horn easier. Okay, so so please take note this. Okay, so for OHE, we did perform the three clamp panicle technique, and always make sure that you ligate at the one that nearest to the body. You don't want to ligate at number 3 and transect at number 1. Why I'm emphasizing here, because in your seniors DVM5 rota still has people ligate at number 3 and cut at number 1. And in even yourself, the DVM3, probably your final in your final exam, or probably your senior final exam, people will draw the diagram to me, but they will like get a number here and then they transect here. So I call this basically you kill the patients on the papers, because the patient will bleed to death. Okay, so cervix is actually a white bulb structure. However, if the patient is pediatric young, you might not able to identify it, or it's not like fully developed. Okay, so in the patients that cats and dogs that had give birth or mature, they are very quite prominent. Yeah. So this is still your clamp number one. This is the clamp that you want to perform your ligature. Okay. Okay. So now we move on to, so basically, we move on to the cesarean section. Is like, so what is cesarean section? It's nothing to do with your Julius Caesar. So it really means from the Latin word sidere, means to cut. So it's delivery of fetus by incision through the abdominal wall and uterus. Okay. So what is the indication of cesarean section? So it can be from a previous history of dystrochia. So dystrochia can be due to the maternal factors, uterine inertia, meaning the uterine that are not able to contract. Pelvic canal narrowing can be due to your pelvic fracture that not repaired. And also fetal factors. Fetal factors also can contribute to the dystrochia, which is malpositioning of the patient or the fetal mother ratio that not proportionate. Okay. So this is the radiograph. Also, you can detect pregnancy with ultrasound. Okay, so now we want to talk about the drug. Very in brief, drug that we want to avoid during the drug that must be avoided during if the patient is pregnant. Okay, so you want to avoid your phenothiazine. Example is your asparmazine, promazine, barbiturate, and ketamine. So you need to choose other more safer drugs. Okay. So for cesarean section, is basically is the approach is almost the same like your OHE. So again, it's the same ventral midline incision. You can start from umbilicus to the pubis, or even from the xiphoid to the pubis, depend on the size of the uterus. Okay, but you want to avoid your mammary tissue. That's why you must stay at the midline and the linea alba. Careful enter to the abdominal, especially when you're making a nick at the linea alba. You don't want to cut through into actually injuring the fetuses inside the uterus. Okay. So so let me see. Okay, so perform a cesarean section, you basically need a big team. Okay, it's just not a normal surgeon, assistant surgeon, NS, and nurses. Okay, it basically need two teams for all. Two teams of surgeon, two teams of NS, and maybe two teams of nurses. Because one the fetus is removed from the uterus, you need actually another team to actually handle the fetuses. Okay, so the surgeon that doing the cesarean section must maintain at the position. Okay, so so the key to success is actually you need to prepare the dam, you need to have a correct sections of anesthesia protocol, fast surgery delivery, and also adequate neonatal care. Okay, so example, you can shave the dam prior to induction, pre-oxygenate, IV fluid. Okay, and then criteria of the drug that you want to use, again, do not cross the placenta barrier. Short acting and rapidly minimally do not depend on liver or renal excretion, and it has usually it can be reversed. Okay, with others drug. Okay, and also you want to avoid fluoroquinolone because it can affect the neonatal development and growth. And also, why we have somebody saying hello? Are you have problem? Can you hear?
I can hear you,
Zhen
Doctor.
Hao. Why Zhen Hao say hello? You have problem there? Okay. Okay, so it's so where okay, so we start from here. So you want to avoid, so it has to be more consideration when you dealing with a serious section, because you need also to consider the fetus, okay, type of antibiotic you use, and so on. Okay, so this is a picture showing basically you just make one. We're going to perform cesarean section generally for breeders. They want to keep breeding the dam. So basically, we're going to perform a cesarean section. And so basically, the flow is you want to remove the fetuses in the uterine body first. So the fetus in the uterine body first, you remove. And then because you know that probably around this horn, you have probably 2 or 3 or 4 more fetuses, you want to slowly milk them and exit from your incisions at the body of uterus, okay? You break the amniotic sac, you clamp the umbilical and remove the placenta, okay? If the placenta is well attached, you want to leave in situ because after the fetuses was born, it's actually normal for body to expel the placenta later on, okay? If you forcibly track it, you might cause a severe hemorrhage, okay? So so this is also the pictures from the splatter book. So you can see slowly milk the fetuses from the uterine horn and then break the amniotic sac and remove the fetus. Okay, so I have a real pictures where cesarean sections that we perform in UVH. I'm going to show you share later. So this actually this show you how we're going to clamp the umbilical cord. Okay, and then if you want to maintain or continue to breed the dam, then you have to lavage, clean, and close up. Okay. Okay. So it's basically just a normal. It's either normal a position suture pattern which is simple interrupted, or you want to invert it. Okay, you can use other type of suture pattern, but basically simple interrupted is no, simple continuous is enough. Okay. So is when you talk about lavage abdominal, you need to also stand by a suction unit, okay, a very powerful suction unit, because if you pour in 1 liter of water, you need actually to make sure you're able to remove as much as possible the water that you pour in for the lavage, okay? So, and then another method is en bloc OHE, okay? It's a rapid removal of the uterus and ovaries before hysterectomy and removal of neonates. So just now, cesarean section, you cut the uterus, okay? You cut the body uterus and take the fetuses out. En bloc ovary hysterectomy, you remove the whole uterus and pass the whole uterus to another team, and then another team will cut the uterus and take out the fetuses. Okay, so there is a slight difference. This is cases when we don't want to continue to breed the dam anymore. Okay, you want to stop the pregnancy forever, then this is what we're going to do, en bloc OHA. Okay, so again, it's the major reason for en bloc is usually a dystocia. So let me share you with our case so you can see. This is from this radiograph. What okay, so you can see here. This poor fella has a pelvic fracture at the left acetabulum. Okay, you can see a narrowing of the pelvic canal. So this is the size, 1.6 centimeters, very, very narrow. Okay, and then you have calcified fetuses, meaning that there's a bone formations already. So basically, these are quite mature fetuses, and also this is a lot of feces. Of course, it has a lot of feces because of very tiny canal width. Probably the feces also cannot come out. So this is actually quite complicated. Not only have to deal with the fetuses, also have to deal with the feces also. So this is the cat. It's so compacted and straining to actually try to give birth, but so we quickly go into the surgery. Okay, this is the uterus, and this is en bloc motion, meaning that we don't even bother to ligate first. We just clamp and cut and actually pass the whole bowl of fetuses to another team. Okay, of course this is a sterile glove. You can see like this is like bangle or something, but of course it's a sterile glove. Okay, so we pass this and then quickly, and not only that, why this is important for you to take an x-ray first, at least you know you have, let's say if you have 6 fetuses, make sure you have 6 nurses. Okay, because when you remove this, you really need to quickly clear the airway and ligate the umbilical cord and provide oxygen. Okay, so very important here. Probably you can count how you want to count. You basically have to calculate the spine. Just now sorry, I go back. How you want to calculate spine? Okay, you calculate 1, 2. Don't count. This is how you want to make sure you calculate the correct fetuses. Okay, so you follow the spine. So if you calculate you have 6 fetuses, make sure you have 6 nurses waiting to take over, because it's really need to be quick. Okay, and this is your what do you call that, the mask, okay, the anesthesia mask. So everyone gets some oxygen, pure oxygen. Okay, a very good, very nice experience here. So we probably have a 1, 2, 3, 4, four babies. Okay, so also this what is this? This is your warm blanket, or you call it bear hugger. Okay, this is actually to control the body temperatures. Okay, this is actually quite happy endings. Okay, so you need 4 nurses, 1 team to open up the uterus, and 1 team to handle the mom. Okay, so the complication that usually relate to this type of ciliotomy or also OHE is basically, I think the one that very special is actually failure to remove gauze or sponges from the abdominal cavity. So if they say there's a drop pedicle, meaning that after you do the OHE, suddenly you can see blood pulling out, you become very nervous and you try to throw all the gauze inside to the abdomen to stop the bleeding. Please remember, always count your gauze. Please remember, always count your gauze, because if you fail to remove the gauze, this is what's going to happen. It's known as gauzy fibroma, also known as RSS, which is a retained surgical sponges, or textiloma, cottonoid. And you can say this as a surgeon or team errors usually, because the surgeon failed to count, the nurse failed to count, the assistant surgeon failed to count. That is why when we ask you to drop the gauzes, please develop a technique. If every time you drop 5 gauzes, it's like easy. So one time you drop 5, 5, 5, 5, you easily calculate and get the numbers. Okay. Okay. So orgasoma. Okay. So all these fancy names, always actually the basic is actually retained surgical sponges. Okay, it can be cottonoid or any type of textile gauzes. So certain surgical sponges come in a very special marker, a radio opaque markers. This can be facilitated during abdominal radiograph. So it has this blue line. They are pretty expensive, or more expensive than your normal gauze that you use. Okay, so when you take radiograph, you can see this line. This line is radio opaque and can be projected or observed. So you know that you accidentally leave 1 gauze. Okay, if without a gauze, then you have this, you thought it's a tumor. Okay, CT scan, MRI, and this one tiny thing. And once you so after some time, so when you leave a gauze in the patient, the problem does not arises immediately. It probably take years, 1 year, 2 years, 3 years possible. Okay, so there's 2 types of response if you leave the gauze inside a patient. One is aseptic serofibrinous responses, meaning that it's leading to adhesion formation, complete encapsulation, and foreign body granuloma, or exudative response, meaning that this has some kind of infection, it causes abscess formation. Yeah. So this is, you can see, this is like a mass that removed, and one after the surgeon cut, they found gauze inside there. Okay, you can see the gauze here. Also this one. They say open up this capsule and actually inside is a gauze, okay? In fact, we have experience when we run the ultrasound in one of the patient, we can find gauze. How? Because there is a human-made gauze like a crisscross pattern. Okay, you know your gauze has this horizontal and vertical line. So when you shine your ultrasound, you can see this. Okay, so we know that this patient having a vomiting, having fever, and we go in surgery and we remove the gauzy lipoma. Okay, so we're done with the OHA, we're done with the cesarean section and en bloc. Now we come to the mastectomy. Okay, so the female reproductive, another one, the most common that you're going to encounter is actually the mastectomy. So it's your day in, day out. Well, because again, our patient live longer now. Last time when I was student, seeing a 9 years old, 10 years old kid is everyone will like, wow, wow. But now I can find easily 15, 18, 20, 21 years old cats or dogs. And prolonged life come with another set of problems. Okay, so the one and most common is actually tumor. Okay, so mammary gland tumors in so you're going to, so the details please probably you can secure from Dr. Gaia lectures, but here we basically just talked about the surgery technique, yeah? So this is a few example or pictures, okay? Some ignorant owners were going to say, oh, this is like yesterday, or this is like yesterday I saw it. Okay, so very, very common excuses. And okay, so for mammary gland tumor, sorry, this is not supposed to be a title. For mammary gland tumor removal, so the surgical technique can be have few: lumpectomy, mammectomy, regional mastectomy, unilateral mastectomy, bilateral mastectomy, or stage unilateral mastectomy, meaning that for the you plan to remove both sides of the mammary gland, left mammary gland and right mammary glands, but you're not going to do like bilateral at once. You stage it, meaning that you remove the left one first, and after 2 weeks you remove the right one, the right side. Okay, so these are pictures or examples of unilateral mastectomy. Okay, when you talk about unilateral, you're going to remove from the first teeth to the last teeth. Okay, and I always encourage you, even though you have a mass at the caudal abdominal or craniothoracic, I actually always take the chance to remove unilateral mastectomy. Okay, I don't even bother to go for regional or mammectomy or lumpectomy. Okay, take the chance when the patient still bright, alert, strong, okay, and young, I as well remove all. Okay, because even though you remove all, you still have the chance that the mammary gland tumor can regrow even without the true mammary gland itself. Okay, so the most important thing when you're doing your unilateral mastectomy is actually to remove the inguinal lymph node as well. So in order to remove your inguinal lymph node, make sure you're able to identify your caudal superficial epigastric vessel. This is a very huge vessel. If you accidentally cut it without knowing you have this big vessel here, you probably end up with a severe hemorrhage. Okay, so when you're done with your last teeth, okay, this is your last teeth, so you want to go slow around here and slowly blunt dissect, look for your inguinal lymph node. It's very important to stitch whether it's already metastasized or not. And also usually lymph node is supplied with a major vessel. So you want to be very careful with that. So we know that for this, you have this caudal superficial epigastric vessels. So make sure you ligate it properly. I usually would double ligate this. Okay, I'm very scared. Okay, so this is a bilateral mastectomy. So we want to perform a bilateral mastectomy in case the growth is still small, but it appear on both sides. Okay, so you can see this surgeon, I think he is getting a 2 cm margin. And then you can see when you do a bilateral, you probably want to, this is probably the design that you want to, because it make your closure easier. Okay, but the problem with bilateral mastectomy is you end up a very huge defect. You end up with a very huge skin defect. So before you even want to embark on your bilateral mastectomy, you have to sit down and think, do I have enough skin to close? If I don't have enough skin to close, what kind of flap that I can use to close the skin? Okay, what kind of transposition flap? And will my dead space a lot? Definitely will a lot. So you can see the defect is very huge. Probably 40% of the skin is removed during if you perform bilateral mastectomy. Okay, so you definitely has a lot of dead space. Then you need to think about how to. When you have that space, you're going to have seroma. So you need to find a way to remove the seroma properly. Okay, if not, this fluid going to seep out from your incision line and is going to cause wound dehiscence, okay, and might end up with infection and so on. So this seroma need to be removed properly. So basically, we're going to use active drainage. However, in overseas, we have this very nice active drainage, but in UPM, in UVH, we're going to DIY, self-made. Okay, so when you come into the main OT during your rotation, we're going to show you how we DIY our own active drainage. But this is very fancy, actually very nice. It's called Jackson Pratt closed active suction drain. So it has this granite, like bontangan granite here. So it's going to suck in all this seroma. So how it suck in? So after this major mastectomy, okay, you put and then you start to make it into vacuum. So you're going to have this aroma form collected, this fluid collected, and you basically can remove with a syringe. Okay, so this is very nice. So in UH, we're using a vacutainer. Okay, your blood tube. So we can change the tube daily because the tube is vacuum. So when you reconstruct it and you can remove the stroma actually as efficient as this, but it has some danger because you're going to leave a needle actually on the patient, but you have to be very careful, make sure that it's very secure. Okay. So radical mastectomy, you want to perform radical mastectomy when when it's very important. That's why it's very important. Before a surgeon even perform a surgery, you must check the patient, you must examine your patient. If you found that the mammary gland, which is having a tumor looking features and is already stick or stuck on the muscle, you need to plan for radical mastectomy. You need to remove the underlying rectus fascia muscle or even the body wall. So this is one of, you can see a one layer of muscle here is actually removed. Okay, the layer that contain the external rectus sheath probably, so it's removed. Okay, so this is radical mastectomy. Or you need to, if sometimes the penetration or the invasions of the tumor is very deep, you might need to remove the whole abdominal wall. So they come in the importance of knowledge of having mesh, surgical mesh. So if you touch the mesh, suddenly you feel there's very deep invasions or penetrations into this, you probably need to hold on the surgery, call supplier, get a surgical mesh, stand by in case you really need to remove the whole abdominal wall, then you have something to patch for the patient. If not, then you probably end up with trouble. So must be planned properly. Okay. So now what to remember? You need to always, before a surgery, ask yourself what procedure you're going to perform, why you want to perform these procedures, your pre-op consideration and care. Okay. So the objective, is it a palliative? Is it sometimes we remove tumors or masses is because we want to stop the bleeding, or because some mass that are ulcerated going to bleed non-stop. Okay, but we know that even with removing the tumor, sometimes the tumor is already spread or met, so it's not a curative, it's more to palliative. Okay, also we need to take note of this pre-operative care. As a surgeon, you need to have the knowledge of pre-operative care before the surgery care. perioperative care, intra-op care. While you're doing surgery, you can't rely 100% on your because you are the one that able to feel your patient moving, jerking, okay? Because your NS basically just based on it's based on monitoring devices, and also probably they also can't really like evaluate anything further under the drape. They probably just the jaw tone, the eye, and so on. So you must able to respond and communicate with your anesthetist, and also your post-op care. Meaning after the surgery, you can't as a surgeon just leave the patient like that. You need to know, you want to do a warm compression, you want to do a cold compression, you want to do a physiotherapy or physical therapy. You need to have those kind of and it has to be planned and right out so that other staff can take over. You can't handle all the case by your own. Okay, so we end for the female part. Okay, now we give me a break of 5 minutes. Okay, I drink some water and we come back for male reproductive system. Okay, thank you.
Thank you, doctor.
Okay, assalamualaikum. So let's proceed to our second topic, which is the reproductive surgery of the male reproductive system. Okay, so let's have a very quick recap of male reproductive system. Sorry, I think I already removed the slide, so I will add on later on. So okay, so for male reproductive system, I think very straightforward. You have your testicles, and then very important, the one that going to cause diseases in that needs surgery usually is the testis, the prostate, and also the penis. Okay, so for basic elective surgery, is always an orchiectomy, or this is a castration. It can be called orchiectomy, orchidectomy, or testectomy. So testis is singular, plural is testis. It can be performed open or closed. So I always recommend for open technique. Okay, so open technique, you open up the tunic and you ligate the vessel individually. So where you're going to perform your castration is actually at the pre-scrotal region, site of castration. This area is known as pre-scrotal region. It's between the scrotum and also the penis, the shaft of penis. Okay. So so this picture is going to show you an open. Then you open up the tunic and you ligate the vessel. Okay, you ligate the vessel. So usually, we're going to perform a 3-clamp technique here and ligate. Okay, so you're going to use. I think we're not going to discuss about suture material here. Basically, depend on the body weight. It can be 2-0 or 3-0 monofilament absorbable. Okay, so the condition requiring surgery. The most um, it's not common nowadays. You probably once a while you're going to encounter this cryptorchidism. So it's very, very important for you to, if let's say an owner bring a male dog or cat to you for castration, make sure you perform a proper PE and really feel for the testicle in the scrotum. Why? If you code it wrongly, this is from the economic point of view, if you code it wrongly, you will lose in terms of money. Okay, you say, oh, castration, you put like 100 ringgit, but actually this is a cryptorchid patient and you need to do an X-lab and look for the testicle that retain in the abdomen. So owner might not happy. You put like 100 and end up with like 300-400 ringgit. Okay, so it is very important. Once you identify this is a cryptorchid patient, you must find, or at least you know, where is the cryptorchid testis retained. It can be retained in the abdominal. It can be retained at the inguinal region, or it can retain at the site of this penis. It's very funny. Sometimes you can find it everywhere around here. So it's also important. Sometimes you cannot. Sometimes you run your ultrasound, look the whole abdomen, you cannot find the retained testis. Sometimes, very funny enough, it's stuck at the inguinal region here, or just under the skin. Okay, so that's why it is very important to really do a proper PE, feel with your fingers and hand where is the retained testis. Okay, if it's not on this superficial region, then that probably means that the testicle is actually retained inside the abdomen. Okay, so let us move. So this is you can see the one with the testis is a bulge, and the one without testis is like almost flat like a normal skin. Okay, so you have to be very, very careful with this. In fact, you might want to shave the patient properly. Okay, sometimes once you shave it, you're actually able to feel the retained testicle is usually on the inguinal or around the shaft of penis here sometimes, okay? After you shave, okay? And I found that the patient on the dorsal recumbency is easier for me to detect the retained testicle around the inguinal and or this periprepuce region, okay? So a little bit facts about cryptorchid. The right testicle is more commonly affected, or meaning that the right testicle is the one that more likely to retain and has a greater risk to become a neoplastic, okay? Because the testicle is exposed to normal body temperature. You know that the scrotal is probably a degree of feel and a little bit more lower than the normal body temperatures, okay? So once it's exposed to the normal temperature, it's likely or at a greater risk to become neoplastic, okay? So Sertoli cell tumor, seminoma. So tumors of the testicle is actually among a question that commonly going to be asked during your comprehensive exam. So you need to know the name of the testicular tumor, okay? So if whether it's a bilateral urinator, you need to remove both the testes, okay? So if the inguinal is similar like when you're doing your inguinal hernia, you just cut it and find it. If abdomen, you need to make a quarter milli incision and you have to reflect the bladder, find your vas deferens, trace your vas deferens. So what is vas deferens? So vas deferens is the structures that convey the sperm, okay, out from the testicle. So so what you need to do is just retroflex your bladder, look for the vas deferens and ligate them and remove it. Don't leave it, okay? Remove the retained testicle. So okay, you must remember this by heart. Sertoli cell tumor, interstitial cell tumor, and seminoma, okay? And 60% of 60% of neoplastic cryptorchid testes are Sertoli cell tumor and 40% are seminoma. Yeah. So the common clinical sign, okay, you can see scrotal or inguinal. This tumor, you can see scrotal or inguinal enlargement because it trapped in the body. It has exposed to normal dominator. So the tumor is going to get bigger and bigger, okay? Or it can present as an abdominal mass, may present as a feminization, bilateral symmetrical alopecia, pendulous prepuce, pneumostatica, sexual attraction to other male dogs, okay, or myelosuppression. All this, I can assure you. And also one thing is actually enlarge of the nipple. Okay, so I see one or two cases. A male dog, but with a very weird large mammary glands. It has this bilateral symmetrical alopecia and also pendulous prepuce. Okay, so it's really you got to pay attention to this sign. Okay, if you found that this dog is cryptorchid and has this feminization, pendulous prepuce, you know, it's very saggy prepuce. It's very like a baggy prepuce. So then you have to start to suspect this patient might have a testicular tumor and warrant a surgery. Okay. And also when we perform an castration or orchiectomy in the testis with the tumor, you really want to remove as much as possible the spermatic cord, including the vessel, including the vas deferens, okay? And the cryptorchid testis usually has a very large aberrant vessel, so you need to be very careful with your ligation, okay? You have to choose the correct size and correct type of the suture material. So now we talk about penis. What condition going to request a surgery in the penis is actually basically is trauma to the penis or penile tumor. The common one is common cell carcinoma or sarcoma. And they usually will lead to a penile amputation. When you have a penile amputation, you need or require to construct a pre-squattal urethrostomy. You can't just amputate and leave it. Then how the urine want to flow? So you need to perform this, amputate it, and make an opening so that the urine can flow. Okay. I'm not sure whether this time how much we can offer to you for your practical experience. If we have time, we're definitely going to go a little bit deeper into your practical, and you can actually try to dissect and see the urethra. Okay, this is inside the penis has a urethra, right? So you basically insert the catheter, urine catheter, and then dissect the penis, transect it, and make an opening here. Okay, so previous condition. There's a few conditions for this topic that are probably new to you. Okay, phimosis. So it's actually a prepuce opening which is too small to exteriorize the penis. So the penis trapped inside the prepuce cannot be extruded. Let's say if the dog need catheterization, you cannot extrude the penis. Okay, so you need to do a surgery to widening the opening. Paraphimosis, the penis protrudes all the time but cannot be retracted. Okay, so you can see all the time is dangling over there, and the problem is after some times the penis can become ulcerated, infected, and might end up with penile amputation. Okay. Also, priapism. So also is erection not associated with arousal. Okay, so you basically this is a spine injury, so you need to treat the underlying problem. At this point, I never see a priapism. Okay, phimosis, paraphimosis, yes, we saw it. Okay, and other diseases beside penis, testis, the one that going to affect or affect the patient is actually the prostate. For me, this is the most difficult among the most difficult organs to handle. Okay, BPH is easy. Benign prostatic hyperplasia is easy to manage. However, prostatic abscess, cyst, and neoplasia, they are very radical, very difficult to manage. Okay, and I have a more failures in managing prostatic issues compared to other system. Yeah, so other clinical signs that associate with the prostatic disease are because the prostate, now you have to imagine the prostate, where is the location? It's situated behind your bladder. Okay, so when you have this abscess, this prostate become enlarged. It's not only compressing the urethra, it's going to compress your colon. Okay, so that's why sometimes you're not sure or you cannot differentiate. This is a bladder issues, or this cat has a mega constipation, obstipation, because it can share the clinical sign of constipation, tiredness, strainuria, dysuria, or even hematuria. Okay, so how are we going to manage it? Castration is curative for BPH. It's helpful in the part of therapy of prostatitis, maybe cysts, and so on. Okay, so cyst resection is not 100%. It sometimes it tend to regrow the cyst. Omentalization. So you take the omentum and wrap around the prostate. Sounds very easy, but actually when it's very difficult to perform and very high level of failure. Okay. Prostatectomy also just remove the prostate. Is basically nothing easy to perform the prostatectomy because you might end up a lot of bleeding, or if this is an abscess, it's even more difficult. Okay, so so you can see here, this is, I can hope you can see, this is the bladder, and you have this mineralization of the prostate. Okay, so, and then another thing is very important is during the PE, please lubricate your finger and feel. Put your finger into the rectum and feel. If this is an enlargement of prostate, you can actually really feel it bulging. If this is BPH, usually they are symmetrical, meaning the left side and right side is almost same size. If this is an abscess or a tumor, they will be quite irregular in size or feel. Okay, so you can see some so this is BPH. You can see symmetry. Okay, a symmetry. So this is okay. So we know that behind the bladder in dogs, particularly in dogs, behind the bladder is actually your prostate. In this picture, you can see the prostate is bigger than the bladder. Okay, so this is a cyst. You have prostatic cyst. You also can have a periprostatic cyst, meaning that the prostate is normal, but beside the prostate, it has these large cysts. Can you imagine? The prostate is normal, but beside the prostate, there's a one big cyst. So this we call a periprostatic cyst. Okay, we encounter also even after remove it, it regrow quickly. Okay, so but actually at the end, the dog cannot make it. So this is a normal prostate. This is prostate with BPH. Okay, so you can see they are symmetrical, and it does not look angry like tumor. You can see irregular or structures. Okay, but this one is look almost similar for BPH. So the castration is the best treatment. You give time 3 to 12 weeks. So meaning that if this is diagnosed as BPH, you might want to call the patient to come back to ultrasound every few weeks to actually measure the prostate size. Okay. For me, don't even think about performing prostatectomy, because the for me the risk is outweigh the benefit. Okay. So so we talk about prostatic immobilization. Okay. As I say, the book make it sound very easy, but it's actually not any easy surgery. So you have to imagine, this is the pictures. So this is your prostate. Okay, you need to wrap the omentum around the prostate. So this is called omentalization or intracapsular omentalization technique. Okay, I performed actually only once in a prostatic abscess, and it's end up disaster. The abscess, when you talk about abscess, you have pus. After I wrap it, actually the pus leak into the abdomen, and this patient died of septic peritonitis. So for me, prostate, unless you are very confident, if not, don't try to even like make an incision and try to wrap it, because the pus or the cyst build up is very quick from my experience. Okay, so you can see this better diagram. You have to, this is your urethra. Okay, so this is your urethra. So you bring your omentum, omentum in from the abdomen, wrap it around. Okay, and ligate it. But a lot of time it does not work for me, but this is one of the technique. I would end up prefer to manage prostate issues with a very strong antibiotics. Okay, I try not to make an opening, because when it leak, the content of prostate leak, it can cause severe septic peritonitis or a peritonitis for the patient, and that is more difficult to handle. Okay. So other surgical male procedures, you can check from here. And again, don't be surprised. You probably need to perform mastectomy or bilateral mastectomy in a male animal as well, okay? Because mammary gland tumor can happen to male and female animal and also human, okay? So we're done with our male reproductive system. So let's move to the other system. Okay, so if you have questions regarding today's lectures, Mira, can you please collect all the questions, okay, from the whole class so that we can have another session to discuss the question, okay? So that would be, I think, fair for everyone that you can know and learn together, okay? So next, let's move on. Excuse me, I have problems sharing the screen. Just a moment, yeah.
Okay, Doctor.
Okay, now, just, can you guys hear me?
Yes, doctor.
Okay, so now we proceed to the surgery of the kidney and ureter. Okay, so they basically, so for soft tissue surgeries, I think the key to be good in soft tissue surgery is actually to know the anatomy and actually to really know the vasculature, what vessels supply the system. So in kidney, you need to know who supply, who drain the blood. Okay, so that's very important when you're learning your anatomy in your DVM1. Really, you have to really, I'm not sure how is the anatomy classes conducted now. Last time, we will come even Saturday and Sunday and to dissect the carcass to learn the anatomy. Okay, so I'm not sure about now. Okay, so we're going to discuss about nephrotomy. So from the name itself, neph is kidney. Otomy, incision into the kidney. Nephrectomy, neph is kidney. Ectomy is excise, remove. Ureterotomy, ureter. Otomy, incision into the ureter. So all this has, in order for you to perform all these procedure, you need to ask yourself why you need to perform this procedure. So the why is actually the disease, okay? So we recap again. So, okay, this is a very nice diagram for a male reproductive system. Okay, you can see in this case, actually, you can see this is your bladder, okay? And this is your prostate, very close to the bladder. In dog, okay? In dog, is the bladder is very close to the prostate, and then you have this urethra, and then you have this urethra and the door to your penis, okay? And this is your os penis, and then you can see your testes, and then this is your vessel and vas deferens, okay? And you see you want to open up your anatomy book again, where it basically stop at this prostate region, and this is your urethra. So it stop or it exit at your trigone region, okay? And this is a female, okay? So kidney, okay? So you probably want to review on Dr. Lau radio notes about how to measure and so on. I'm not going to discuss in detail here, okay? So you can see from the radiograph, this is the kidney, okay? So this is, so you know, right? This is a dog and this is a cat. Okay, by looking at the formations or the features of the spine. Okay, it is more cuboidal, this is more rectangular. Okay, then the kidney here, you can see very clearly your colon and all. Okay, so common procedures performed in your kidney. One of it is actually renal biopsy. It's actually more done by Dr. Lau, ultrasound guided. Sometimes if they need a bigger piece of the kidney, they probably refer to me. So we're going to do an open surgery, okay? So ultrasound guided. So you want to avoid the arcuate vessels at the cortical mini junction also. This is the arcuate vessel. So you want to be careful. If you're not very clear here, really take your own initiative and go and open up the anatomy books to find what is those vessels are, okay? So we have cases with ultrasound guided. After that, patient end up bleeding. We still have to go in and doing an open surgery, okay? So the straight line is a correct renal biopsy tract, okay? You want to just biopsize the cortex, okay? You don't want to go anywhere deeper, okay? So this straight line is correct. This is incorrect, okay? Because this really will cause problem. Yeah, so the straight line is this is you want to avoid. That's why you must have an ultrasound guided. Don't blindly do it, okay? So nephrotomy is surgical incision into the kidney. So I never perform a nephrotomy in clinical setting, meaning that cases coming in, the stone in the kidney, Dr. Lisa, today we're going to do a nephrotomy. I has no experience doing it, and I probably would not dare to do it because I feel the benefit or the complication is outweigh the benefit. Okay, unless we are properly trained, because I think the post-op management will not be easy. Okay, so if we have stones in the kidney, usually we really go for a dissolutions diet. Okay, we try to uh, make the stone smaller and probably can be flushed out. I know it's difficult, but usually we not try to remove the stone by performing a nephrotomy. Okay, yes, books they describe, but in reality, I don't have experience to do that. Even with my studies in overseas, I don't see my supervisor doing it. Okay, so most of the time they will go very conservative, unless it's like a total blockage. They would probably choose a nephrectomy, basically remove directly the whole kidney. Okay, but that's provided if one of the other kidney is normal. Yeah, so you can see there's a nephrolithiasis. Okay, nephrolith, kidney stones. Okay, so nephrotomy is traumatic to kidney and should not be carried out unless absolute need. Okay, so You can dissolve the calculus in situ by calculating diet, antibiotic, and pH changes, and it has to be followed up by radiograph and also ultrasonography to measure. Okay, so so books describe, but in practical class, you can have the experience of performing nephrotomy, opening up the kidney and observe the anatomy, fresh organs, okay, for your own learning. But in real life, the books also say that it's less absolute, okay. So we usually don't do that, okay, because if you do not properly, after you open up, if you not properly close it, high chance that you're going to have urine leakage and hemorrhage. So there's more complicated to handle, because we know that urine, if it go into abdominal cavity, one of the most easy things you can think of is peritonitis. Okay, so it's not easy as described in the books. So this is a nephrotomy. We just make an incision. They say they make an incision, and once you open up the capsule, you do not cut directly. You basically actually tear it open, like you peel the banana skin using your hemostat. Okay, so and then you have to really have this double layer to string up it. Even with this, you still can have urine leakage. So that is a major concern. Okay, the complication, really the kidney can die itself. Okay, so iatrogenic renal infarction. So possible, please avoid this. Okay, nephrectomy, okay, removal of kidney. So the indication for renal neoplasia, just a moment, student. Renal neoplasia. So why we want to perform a nephrectomy? Renal neoplasia, severe trauma resulting in uncontrolled hemorrhage, example like accident, okay, or some dog kicked by certain people, abuse, so that can cause a severe hemorrhage. Urine leakage, okay, pyelonephritis, hydronephrosis, okay, and abnormal rupture and so on. It also gives you the reason why you need to perform a nephrectomy. So renal neoplasia, I think the most common is carcinomas, okay? And also you have to check for evidence of mets, okay, before and during surgery. And very important to discuss the prognosis, okay? For me, renal neoplasia is treatable as long as it's not mets yet, okay? So very important, actually owner detect early. Unfortunately, most of the time, owner bring in the patient very, very late, okay? So owner should be prepared for the possibility of euthanasia of the patient during the surgery. So this is, you can have a look at these papers. Okay, so it majority is carcinomas, okay? And then sarcomas and nephroplasm. This is from the studies in Missouri, Columbia, is okay, primary renal neoplasia. So you can see a very huge mass, and it's a tumor, okay? It's a kidney. So, or this is you can see a normal morphology of kidney, okay, medulla and cortex, and this is the one that invading the kidney tumor, okay? So again, this is always a dorsal recumbency ventral midline incision. So if you want to perform a nephrectomy, which structure first? The blood vessel or the ureter? Okay? So you want to ligate the vessel first, as ligation of the ureter before vessel result in renal swelling as urine is continue to produce, but the urine cannot flow out. So you want to ligate the vessel first, okay? So because kidney is not a structure that like your intestine, your liver, that floating in the abdomen is actually a structure that secure at the behind the peritoneum. Okay, so you need to open up this peritoneum, okay, and detach this kidney from the perirenal fat. So you can see this is actually stick to the wall. Okay, so you need to open up this peritoneal layer and double ligate the renal artery. Okay, you need to double ligate because you can see it's a direct branch from this abdominal aorta. Okay, you need to ligate three important structures here: the artery, the renal vein, and also the ureter. The ureter you want to ligate near the bladder. Okay, so this is another picture, as you can see. So you want to ligate the artery, and then you ligate the vein, and then you ligate the ureter near the bladder. Okay, you don't want to cut halfway here, really, really close to the bladder, and all must be double ligate. Okay, the one that you leave into the body is double ligate. One of the pictures here, you can see this is the hydronephrosis. Okay, so when you talk about hydronephrosis, when you open now, there's nothing there. There's no medulla. There's no aqueduct. It's basically just a fluid. Okay, and you can see the ureter is humongous in size. Okay, and you need to remove the whole length of the ureter. So the complications of nephrectomy, basically, it's actually straightforward procedure, easy to perform. So usually it's hematuria, and you're going to see, you can see the blood in the urine up to 3 or 4 days, and microscopically up to 1 week. Okay, microscopy mean that you cannot see with your bare eye, but if you put under the microscope, you can see the RBC floating. Okay. And pylorhistotomy, this is pylorhistotomy. I performed few times. Yes, if the stone at the renal pelvis and proximal ureter, if you have a proper size of instrument, a proper size of the suture size, you can perform it. Okay, and it can be successful. Yeah. So sometimes the stone stuck around here, so it's quite straightforward also. Okay. Let's see. And so from this diagram, you can choose either to suture vertically or longitudinally. I will always choose this method because this one highly going to cause a narrowing. Okay. But despite whether it's horizontal or vertical, in literature they always stated that a stenosis or narrowing of the ureter is highly occur in all ureterotomy, meaning that ureterotomy incision into the ureter. Okay, so you need very special equipment. You need operating microscope. You need a very small vessel, 6080. The one that you always see is small enough, right? 3020. This is 6 to 6080. Even 90 if you want to connect or oppose or join nerve. Okay, they are really fine, and you need a magnifying glasses. Okay. So you have these stricture formations. That's why after ureterotomy, you want to do excretory urography, meaning that you inject dye into the vessel and then wait for the urine production and evaluate the ureter. Okay. Okay, so another one is probably new for you. So it's known as a subcutaneous ureteral bypass. Okay, so if you have stone or whatsoever at the ureter, this is actually a device. Okay, and it acts as a artificial ureter. Okay, saying that all these implant does not mean it always come with a complication. Okay, or so you got to be very careful. And I never performed this, okay, but probably see once. You can see this from this link that I gave you, subcutaneous urethral bypass. It's basically a device that planted in the patient, and as I said, it does not come without complication, meaning that almost every cat that have this, it probably prolong the life, maybe give a few good quality of life, but again, most of the time, but however, probably with improving of the technology, the device going to be work better and better. Okay, so for those that are interested, you can read more about this. Okay, so you can see this is a very interesting papers published. So this is what you can accidentally do if you are not careful with your ovarian hysterectomy. Bilateral urethral ligation. So the surgeon accidentally ligate bilateral of the urethra. So why this is very important? So I'm sorry, I have to scroll the slide. Go to the first one. You can accidentally ligate. So you want to remove your uterus, right? This is your uterus. You can actually ligate together with your uterus if you're not careful enough. That paper produced is lucky because they are not yet transected. If you transect it, then you can say goodbye to the cat. Okay, so I want to be very, very careful when you're doing OHE. A cheap procedures end up have to put on this implant, so it's definitely not a cheap procedures. Okay. Okay, so we're done with nephrectomy, and urethrotomy. Subcutaneous bypass is actually a technology, and it's good for you to know. Okay, but not that you need to know in depth. Okay, it's good for you to know. Okay. So the last one. Okay, we go for the last one. Can you guys see my slide?
Yes, doctor. Can,
Okay,
doctor.
so just now we talked about kidney. Okay, so the major procedures, actually the most commonly do for me is actually nephrectomy. Okay, the most commonly do. Okay, so now we're going to talk about the lower urinary system, which is the bladder. Okay, so we're going to discuss cystotomy and perineal hysterectomy. Cystotomy and perineal hysterectomy is actually the two most common urinary procedure that perform. Okay, cystotomy, the skill level is not that high. Okay, basically just incision, and but perineal hysterectomy, you need to have very good knowledge of anatomy in order to perform a very good construct a very good opening, so that you can prevent a stricture formation. Can we take 5? I drink water and go to the washroom, and we can come back. Okay.
Yeah,
Okay,
doctor.
doctor.
Assalamualaikum. So we come back again. So for this part, we're going to discuss about the tissue handling, the principle and tissue handling, anatomy, and also the cystotomy, perineal, urethrostomy, and urethrotomy. Okay, so tissues of urine are very delicate. You need to have a careful handling. Always recommended to use scalpel rather than scissors because scissors are too crushing. You want to use a fine forceps like accent and use these sutures to minimize handling. Okay, if you keep pressing handling with your hand, you can cause actually more trauma. Okay, so this is accent. They are very fine. You can see the tip is very fine. Okay, so 2 times 1 means two teeth on the tip and 1 tooth at the another arm. Okay, so this is called like different arm. Okay, so when they secure it, when you hold the tissue, it causes a minimal crushing injury. Okay, so you can see this is the stay suture, so that you can, and then you can see this packing the bladder, and this is cystocentesis performed. Usually you want to use the smallest gauge needle, hypodermic needle you have. Okay, so cystotomy, why you want to perform a cystotomy? So usually you want to remove a large cystolith, urethral stones that hydropropulse or retropulse into the bladder, meaning that the stone is in the urethra, but we flush it with the saline and it retropulse into the bladder. So you want to remove the stone. Cystotomy also can be actually bladder tumors. This is more like cystotomy, cystectomy, a combination. Okay. Also bladder ruptures and repair. So basically for I enlarge this photo. So this is your bladder. Actually, you have to be very, very careful when especially actually the urethra when you do a surgery. Okay, so the surgical, you can do a ventral wall or the dorsal wall. Okay, so usually when you see your patient is actually on this position, I flip it. So this is a dorsal recumbency. So once you do a caudal, a midline skin incision and step into linear armor, you can see your bladder first. Okay, and then actually this urethra is embedded in the fat. That's why you don't really see your urethra. However, you know that when you see a big 2 lump of fat, that's your urethra. Okay, so you can make the incision here for cystotomy, or you can flip it, retroflex it, and make it at the dorsal wall. Okay, so so this is a simplified diagram. You have your apex, your trigon. Okay, so this is where your urethra exit into your bladder and proximal urethra, and this is known as the uretero-vesicular junction. Okay, urethral, the junction between the urethra and the bladder. Okay, so this is a very good diagram. There are major differences between the prostate. This is dot. So this is the bladder. Immediately after the neck, you have this prostate. You can see the ductus deferens come into the urethra that encapsulated by the prostate. Okay, it's very complicated actually. Okay, for cat, you have this bladder, and then you have some space before you met your prostate. Okay, you can see the difference. Okay, we can if you have time, you probably want to study a little bit more. Okay, even the bulbous spongious muscle is actually more thicker than in cat. Okay, so this is the differences. Okay, so for surgical technique skin incision, we always know that for male, you have to do a deviation. For female, it's straightforward. Okay, so always put a stay sutures and also isolate the bladder because urine can be harmful. So you want to make sure no urine actually drop into the abdominal cavity. So we really pack it with a sterile gauze. Okay, so you can see. Okay, so place the suture at the apex. So again, it's the pictures. So always ask needle gauge location, needle incision, where you want to always perform your where you want to insert your needle. So look at this you want to insert at the apex or the body. So usually you want to insert at the avascular region, meaning that the area of the bladder that has no vessel and away from the apex. Because when you drain your bladder, the size of the bladder going to constrict. Okay, so you want to be somewhere around here, so that when the bladder constrict, it does not affect the locations of your insertions of the hypodermic needle. Okay, so this you can see, you can have 4 stay sutures, make an incision and remove the bladder stones. Okay, and so very important to remember, for bladder suture, you do not penetrate the mucosa. You can do a single simple continuous suture pattern or a double layer. If the bladder is very flaccid, very big and flaccid, you can do a double layer. Avoid multi-filament sutures. That's why you must always remember, go for monofilament absorbable suture material. The most common one in UVH or in Malaysia is PDS. Okay, and avoid sutures not into the bladder lumen. Okay, avoid the sutures not in the bladder lumen. So again, you're going to have, after you performing your cystotomy, you're going to have post-op 24 to 30 hours of hematria, meaning that you're going to see red urine, very common. Okay, and we always love to have this closed system so that we can monitor the urine output and also the urine color. Please start your antibiotic. If this is have a sign of infection, send the urine for culture and antibiotic and sensitivity test. Okay, and also if this is a stone, please consider, or you must have a diet management. If not, the urine is going to recur again and again and again. We have cases that patient coming in to perform a cystotomy for multiple times because owners just too much ignorant or too don't bother to really take care of the diet of their pets. Okay. And one more thing is bladder ruptures. Okay. Of course, taking history is very important. As a surgeon, you also need to review the history. Okay. And also you can do a abdominal tap. And if this is a urine, you can smell a very strong urine smell. Okay. So how to confirm? You can do a contrast, so you can see leakage or contrast. And okay, so usually an accident patient come with a if there's a bladder rupture, usually the bladder is quite bad. Okay, the whole bladder is, not only that, if this is a accident patient, the few things you want to put in your mind: does this patient has a diaphragmatic hernia? Okay, or this patient have a pelvic fracture? If accident patient, so you have to really evaluate them before you go into the surgery. But of course, bladder rupture is emergency. Okay, even though it's emergency, if you not properly prioritize which procedure to go in first, you probably kill the patient. If you're going in, try to repair the bladder, but at the same time, this patient have a diaphragmatic hernia, you probably end up with trouble. Okay, so really have to really check road traffic accident patient. Okay, and also transition cell carcinoma.
Hello, doctor. Isaac, can you hear me?
The doctor just stuck.
Okay, I'll WhatsApp doctor. So, is doctor missing? Okay, bentar. IPM dah. Okay, sekejap doctor is typing. Guys, so doctor says her internet is not good, so we'll stop the lecture now and then we'll continue tomorrow lah, 12 p.m. to 4 p.m. Okay, good night everyone. Thank you.
Bye.
Thank you.
Thank you.
Mira.
Bye.